Hello everyone. Today we are going to talk about drugs that modulate calcium levels. So, before going into this, let us first understand serum calcium levels and bone calcium levels. We already know from our physiological background that vitamin D, parathormone and calcitonin are three such naturally available in our body and they affect the calcium levels. Vitamin D increases serum calcium levels mainly by increasing the GI absorption as well as reducing the renal excretion. It also increases the bone calcium deposition. Parathormone also increases serum calcium levels and it mainly increases serum calcium levels by increasing the osteoclasts. So, bone calcium will be reduced. Calcitonin reduces the serum calcium levels, but it inhibits osteoclastic activity, because of which bone calcium levels increase. This background is very important. So, vitamin D is very helpful to treat osteoporosis, whereas parathormone causes osteoporosis. With this background, let us go into the disease which we all are concerned about, that is osteoporosis. Osteoporosis is reduced bone mineral density with a T-score of less than 2.5. Now, obviously, we have to treat osteoporosis. To treat osteoporosis, what are the major goals? So, how can we treat osteoporosis? Obviously, by inhibiting osteoclastic activity. Second thing is by increasing osteoblastic activity. Third thing is by doing both. So, before going into the drugs which cause all these things, let us first see a basic physiology of bone resorption pit. Pre-osteoclast usually exists and osteoblast usually exists. This pre-osteoclast has rank on it, receptor activator for nuclear kappa beta. Okay, this is the rank. Osteoblast secretes two ligands. One ligand is rank L, rank ligand. The other one is osteoprotegerin. This rank ligand comes and binds to the rank here, which results in activation of pre-osteoclast to osteoclast. Okay, so what usually happens is in a resorptive pit, in normal healthy people, there will be a fine balance between osteoblast and osteoclast. Osteoblast and osteoclast. In a normal person, in a osteoporotic person, this balance will be gone. Osteoclastic activity will be much more. Osteoblastic activity will be less. This results in osteoporosis. Now, what we have to do, either we have to inhibit this osteoclastic activity or we have to improve this osteoblastic activity to come to this fine balance to maintain our normal bone health. With this background, let us see what are all the drugs which modulate osteoclast first. So, they include obviously calcitonin, which we have seen already. Second one is bisphosphonates. Third one is drugs which modulate estrogen. Fourth one is Denosumab, which is a monoclonal antibody against rank, so that osteoclast is not activated. Finally, calci-mimetic drugs. These are the drugs which modulate osteoclast. Now, we will talk about drugs which promote osteoblast. There is only one drug in it and it is Teriparatide. Finally, drugs which have both the action, that is both inhibits osteoclast and promotes osteoblast, is strontium. With this, let us first start about bisphosphonates. Bisphosphonates are very important question for you. It's a very often asked question and is very often used for treatment of osteoporosis. Bisphosphonates, they include Etidronate, Alendronate, they all end with dronate, Ibandronate, Zoledronic. At least let us know for this class purpose, these are sufficient. Etidronate is a first generation bisphosphonate and is not used now. Alendronate and Abaloparatide comes under second generation. They are primarily orally given. Zoledronic is a third generation bisphosphonate and is given parenterally. Now, how do they act? Mechanism of action of bisphosphonates. Bisphosphonates have very high affinity for calcium. In a case of osteoporosis, there will be increased resorption, because of which there will be active resorptive pits. Active resorptive pits will be acidic in nature. Because of this acidic nature, as well as acidic nature, as well as lot of calcium, whatever bisphosphonates are given will be, whatever bisphosphonates are given will be accumulated in the resorptive pits only. This resorptive pits have osteoclasts in them. This osteoclast, activated osteoclast, actively accumulate your bisphosphonates and cause increased apoptosis of osteoclasts. Second thing is, they inhibit the mevalonate pathway in osteoclasts. What is mevalonate pathway? Basically, it is a pathway for your cholesterol. Yes, cholesterol is very important for cell membrane. Once cell membrane is not there, your osteoclastic integrity is gone. And thirdly, for the activation of osteoclasts, it's not just rank which is important, but also interleukins, which we have spoken here. Yes, it is not just your rank, but also interleukins. So our bisphosphonates will also inhibit interleukin expression. Because of these three, bisphosphonates inhibit osteoclasts. So osteoclastic action is gone. Now, let us talk about certain important pharmacokinetic features. Most importantly, it has very less oral bioavailability, and because of their very high affinity to the calcium, they have long T-half. And they are excreted through kidney, renal excretion. Now, where are they used? Obviously, osteoporosis. Any osteoporosis, be it senile osteoporosis, be it steroid-induced osteoporosis, be it postmenopausal osteoporosis, treatment of choice is bisphosphonates. Second one is hypercalcemia of malignancy. This hypercalcemia can be either because of metastasis or because of paraneoplastic syndrome. Whatever it is, if we want calcium levels to reduce, we use bisphosphonates. If this calcium levels are to be reduced by emergency, then we use calcitonin, which we'll talk later. Then comes Paget's disease. Only in the early Paget's, where there is lot of osteoclastic activity, we use bisphosphonates. Then what are the adverse effects? All bisphosphonates are nephrotoxic. All bisphosphonates cause osteonecrosis of jaw. And all oral bisphosphonates cause refluxive esophagitis or erosive esophagitis. This is very, very important. The esophagitis will be so severe that we advise the patient to take them on empty stomach, so that even regurgitation will not happen. And we'll ask the patient to take with full glass of water, so that gastric emptying will be very fast. And we'll also ask the patient not to lie down 30 minutes after taking the bisphosphonates. All these are just to avoid your erosive esophagitis. Clear? Now with this we have finished bisphosphonates. Then comes calcitonin. See, there is nothing much to tell in calcitonin. It is primarily used intranasally and it rapidly reduces serum calcium levels. So this is primarily used for rapid emergency correction of hypercalcemia of malignancy. There is nothing more to add with respect to calcitonin. Now let us talk about the third group, estrogens. See, with respect to estrogens we will read again, but for this class purpose let us restrict to raloxifene. Both hormone replacement therapy at some point of time was also used, and raloxifene is now used in postmenopausal women for treatment of osteoporosis. So we'll restrict to only these: estrogens, hormone replacement therapy, and raloxifene. We'll talk only about their action on bone, their action in blood, their action in liver, incidence of breast cancer. Only these will bother. Rest all, this is beyond the purview. Then we will also talk about endometrial cancer. With respect to bone, estrogen increases the bone mineral density. Blood, it increases the HDL, thus it has very good, thus females have better cardiovascular health. With respect to liver, it increases the coagulation factors expression. So hypercoagulability will be reached. breast cancer incidence increases, endometrial cancer incidence increases. When we give hormone replacement therapy, what I mean by that is estrogen is combined with progesterone. Bone mineral density increases, HDL increases, liver coagulation profile, I mean your coagulation factor expression increases, breast cancer incidence increases. Only thing which reduces is endometrial cancer. So, hormone replacement therapy has a benefit in postmenopausal women, but it also has lot of side effects. There comes our selective estrogen receptor modulator, that is raloxifene. It increases bone mineral density, it increases HDL, and it also increases coagulation factors. But breast cancer is gone because it is an antagonist. The incidence is not increased, as well as endometrial cancer is also not increased. Though it is very good because of the issue of increased coagulation factor expression, raloxifene is not first drug of choice in postmenopausal women osteoporosis. But to whom we should give? We can give them for any female who has a family history of breast cancer and endometrial cancer and is at risk for postmenopausal osteoporosis. Now we will talk about Denosumab. Denosumab also has very little role. It is very costly. It's a monoclonal antibody, so given only parenterally. And second thing is it is a monoclonal antibody against rank. So osteoclastic activation does not happen and is used in bisphosphonate resistant osteoporosis. Rarely we use it here. Now we will talk about the last group, that is calcium mimetic drugs. So we will talk about Cinacalcet. What happens is your parathyroid glands has a calcium sensing receptor. Blood calcium levels act on this and helps in. If the blood calcium levels are less, then parathormone will be released from the parathyroid gland. Clear? Parathyroid gland. So what happens is, in the case of Cinacalcet, it directly stimulates calcium sensing receptor. So stimulates calcium sensing receptor, because of which parathormone will be released. Clear? And now let us talk about the drugs which increase osteoblastic activity. There is only one drug, that is Teriparatide. Sorry, a small correction, I got just carried away. Stimulates calcium sensing receptor, yes. So because of which parathormone will not be released. So any hyperparathyroidism case, we use Cinacalcet. Now let us talk about Teriparatide. Now we will talk about Teriparatide. Teriparatide is recombinant parathormone. Parathormone is basically a 84 amino acid molecule. Teriparatide is a small part of parathyroid. It contains only 1 to 34 amino acids of parathormone. And this teriparatide primarily increases osteoblasts. So calcium deposition increases. Calcium deposition in the bone increases and is primarily used in the treatment of osteoporosis. Whatever osteoporosis it is, we primarily use osteoporosis. Now, one thing what we have to add here is teriparatide is advised to be taken only for the duration of 2 years. It is given parenterally and subcutaneously. What I mean by that is parenterally, and even though teriparatide is given, bisphosphonates must also be used. So teriparatide is given only under the cover of bisphosphonates. Clear? Now let us talk about the last drug, that is strontium. Strontium is not used enough for treatment of osteoporosis, but it causes both. It increases blastic activity as well as reduces clastic activity. With this, I think I have finished all the concepts of osteoporosis. Thank you for patient listening.